Good morning on the West Coast. Good afternoon on the East Coast. This is Kevin Kirkpatrick, the CEO of Avery Professional Group. Today, I am joined by Dr. Laura Jordhen. Dr. Jordhen is on the West Coast, so it's morning for her and afternoon for me. We are just going to chat a bit about Dr. Jordhen's experience in specific areas like home call and stuff like that, and the value and the benefits of that. So, what I'd ask is, Dr. Jordhen, is if you can say hello and introduce yourself.
Good morning. I am Laura Jordhen, family physician. I've been in practice over 20 years. I work in Portland, Oregon, and I work for house call providers, and I do all home visits. Been there just since earlier this year. I was doing home visits with a different group before that, and I love it. Home visits are so special and so unique. I'm just really happy to be here. Thanks, Kevin.
Awesome. Okay, so my first question: what about home care visits is the attractive spot for you?
Yep. So think about all you can learn about a patient when you're in their home. Family is present. You see how they live, what they eat. Practical things like fall hazards, looking at their medications. It's one thing if a patient in clinic tells you, yes, I'm taking all my medications, but then you're in the home and you see, oh, they last filled this in 2021. I think we have an issue. Or seeing the positive things, the support they have, and being able to involve the family as well, and being that resource for the entire family. We are seeing the most vulnerable patients, medically fragile patients, and it really takes a team to support them. And in the home, getting to be part of that team is so critical. Plus, my visits are usually an hour.
Oh, wow.
As opposed to having to get through all of these complex issues in 20 minutes, 30 minutes. It's an amazing way to really give good quality care.
Awesome. Given that you've got to drive between patients and stuff like that, how many patients would you see in a day?
Yeah. Personally, my job with house call providers is to do more fill-in work right now for people who are on vacation. So I may not see that many patients in a day, and a lot of it is managed virtually. But for somebody with a full-time continuity practice, up to 6 a day.
Okay.
And when you think about how deep you can go in the care of 6 people versus 20, 30, you can see the difference. Now, we don't have any simple visits. So these are really complex patients, but it allows time to have those conversations around your code status. What does it really mean if you want chest compressions or not? What does that actually translate into? And really helping patients make the decisions that match their own values.
Awesome. How did you get into the home call visits and and stuff like what was it the time with the patients that encouraged you to do that?
Yeah, absolutely. So that's the biggest thing, is having that time to feel like I can really address the critical issues and not just put Band-Aids on it. I had been with a different company prior. Shout out to Dr. Chad Lowe. I'd worked with at Adventist many years ago. Not the actor, but Dr. Lowe is an amazing human being, and I had worked with him prior to 2016. He was with a group that does home care, and he's such a quality guy. I'm like, okay, if Chad's doing it, I got to check this out. Whereas with before, it wasn't actually primary care.
Okay.
So I wanted to get back to real primary care, continuity care. I am the point of connection for these patients and the rest of the medical system.
Okay. What is this like how, the economics of this are curious to me, obviously,
Right.
because like, do these patients have to pay more, or are they Medicare, Medicaid patients? Like, how does that work?
Right. When you think about, well, how could you possibly keep the doors open if you're seeing 6 patients a day, not 20? We are part of Care Oregon, which is uh, it serves patients with Medicare, Medicaid, and it's I get to serve the most vulnerable patients. There
Okay.
are models where people are paying a retainer, monthly fee, direct primary care. Lots to love about that. Um, and I've thought about that, but I wouldn't get to see the people who couldn't afford to do that.
Yeah.
So in taking really good care of people who are homebound, what we're doing is they're not having to go to the emergency room. They're not having to go to the hospital. And in a model where um, we can benefit financially from those savings, then it's actually feasible.
Yeah.
It takes a reinvention
Yeah.
of the payment structure, but that's how we succeed, is by the really good quality care we're giving, and people aren't needing to go to the ER for a minor illness
Yeah.
because that's the only option they have.
Well, it's interesting. One of my clients, it's been years now that since we worked with them, but they did home care up in Ontario, Canada. But one of their major clients were long-term care homes,
Yeah.
and mostly long-term care homes and not retirement homes. But their philosophy was, if they could schedule a home call, it prohibited that patient from having to get into an ambulance
Yes.
to go to the hospital, right? Because often that was the only primary care they could get, was, to head to
Yeah.
the local emerge. So the several of the homes bundled up and
Hmm.
and had created partnerships with them to keep those
Hmm.
people from the emerge, right? And
Yep.
it's a cost savings at the end, and
Hmm.
it's better care and stuff
Hmm.
like that, right?
Hmm.
So
Yep. Absolutely.
have you
So yeah. Go ahead.
have you seen any literature to support better outcomes through home care?
Yeah, 100%. So um, we have great numbers, and we were talking about this earlier this week, about the cost savings. And I'm seeing if I have those in front of me. I don't have numbers to quote for you right in front of me, but where we see, I mean, there's hard data for house call providers reducing that expensive care, um, by giving really good care
Yeah,
up front. So yeah, it's effective, and the human aspect is profound as well. When it's the continuity, I mean, in the ER, obviously you can't have that.
yeah,
Um, and when a patient trusts you, they follow your care plan, and there's great data on this,
yeah,
that um, communicating effectively, developing trust, rapport, then patients take their medications.
yeah.
Patients follow what you recommend, and that,
Well, yeah, yeah, and you can avoid things getting worse
yeah,
as well, right? And it's
yeah,
I go back to my grandmother. Sorry,
yeah.
unfortunately passed away years and years ago, but of
Mhm.
cancer. But she did palliative care in the home, and
Yes.
it seems so silly to me to say, but it was an amazing experience during a horrific time, right? So
Yeah.
the
Yeah.
respect and the care for us, for her, but also for her family during that process was was unbelievable, because it was not a case of in and out of the hospital and and such. And they were there every couple of days and managed her medication, managed her her care plan and stuff like that. And it made a very difficult situation quite, quite, doable, right? I guess, for
Yeah.
lack of a better,
Yeah.
a
Yeah.
better word, right? So
Yeah.
it's
Yeah.
it's interesting. How widely adopted is house calls,
Hmm.
from
Hmm.
your experience? Like, is this something that's
Hmm.
being done enough, or should we be doing it more?
Yeah, we should be doing it more. 100% should be doing more. Only 15% of people who are homebound or nearly homebound have access to
Oh
visits
wow,
in the home. Yeah. So there's a huge need there. I'm glad you brought up palliative care. We provide palliative care. We have hospice as well. Hospice is, by definition, in the US, you estimate you have a 6-month prognosis. But there's so much space between um, usual care and hospice. Palliative care is not hospice. It's not people who are in imminent risk of death. It is
yeah,
managing symptoms. Um, and that can be really powerful, as you saw.
yeah,
And to be able to deliver palliative care in the home is so effective in reducing anxiety and managing pain. And patients with dementia
yeah,
say leaving the home for them is so confusing and disorienting. So to
yeah.
be able to come to them
Yeah,
is
it's interesting. I talked to a
yeah.
family physician that does a lot of palliative care, and they were developing call it a toolkit for family
Mhm.
physicians to
Yeah.
to to do the palliative care and stuff in the home,
Mhm.
because they did,
Mhm.
they weren't at that hospice spot and stuff like that, right? So
Yeah.
it
Yeah.
it was really more of a case of, like really truly embracing it,
Mhm.
instead of forcing people into the palliative system early.
Mhm.
um, this was the
Yeah.
goal, right? So it's,
Yeah.
it's interesting, because I have my father-in-law lives with us, and he had a major stroke years
Mm.
ago, and the last time we took him to his doctor, it cost $1,000, and that a lot of that was, he's wheelchair bound, immobile. A lot of that was the
Mm.
transit, right? Just getting him there,
Mhm.
right?
Mhm.
So,
Mhm.
I would happily pay $1,000 to have somebody come and see him, to avoid
Yeah.
that, right? Because my
Yeah.
mother-in-law is lifting him
Mhm.
into a car
Mhm.
and stuff. Like, it's just, it's
Yeah.
not it's not. I mean, again, it's not intended to be mean, but it's not really a respectful means, right?
Yeah.
To sit here and say,
Yeah.
you need to come somewhere for a
Mhm.
5 minute visit, right? Like, it just,
Right. Right.
it doesn't make
Mhm.
sense, right? So
Absolutely. Absolutely. Yeah. And palliative care can be seen, there's a risk of patients seeing it as, oh, you're giving up on me.
yeah,
There's nothing more to do. Um, when it's so different, I'm glad you experienced the benefits of it, that you were able to see that firsthand, that it's not doing futile care. It's
yeah,
not doing unnecessary care. And who needs that?
yeah,
So having that real in-depth conversation with patients about, well, if we follow this treatment plan, here's what you might feel, here's what the expected outcomes are, and this is absolutely a choice, but is that the outcome you want? Is that the quality of life you want
yeah.
right now? Um, and to have those really informed decisions. And
Well,
that
it's interesting, because
Mhm.
I was reading about a hospital somewhere, and I don't remember what it was. It was in the U.S. They stopped referring to their palliative unit as a palliative,
Oh.
uh, because they were having people that were going there that weren't going to be, deceased in the short term, right? And they felt that the
Mhm.
notion of putting them into an environment that's deemed as the end of life care, um, was
Mhm.
disadvantageous, right? Because,
Mhm. Mhm.
someone could, it's this notion of, living with, as opposed to dying with, or dying
Yeah.
from, right? Like,
Yeah.
so
Yeah.
it was really quite interesting to see that they were looking at how they, even just the language they used
Mm.
around it, because they didn't want that preconceived notion, right? So,
Mhm. Mhm.
it was interesting, and I think, do you guys does your organization find it hard to recruit physicians to do palliative care?
It is hard to recruit across the board in
Yeah,
primary care. So yes. But once somebody has come to us, our turnover rate is really low. Our
yeah,
longevity in the organization. I'm working with people who've been there almost 20 years.
yeah,
Several people more than a decade, and that really speaks to how meaningful this work is, how sustainable it is. But it's unique. It's a really different kind of care to then enter in the home, and you don't have the exam table, you don't
yeah,
have the great lights, and so doing a skin biopsy
yeah,
in a home and strategizing about that. And if you forget something, it's not in the drawer, it's not down
yeah,
the hall.
yeah, yeah, yeah,
um, so it's for clinicians who are really resourceful. Takes a lot of confidence because,
yeah,
again, you're in this setting alone. We always have each other to consult with, but you don't have somebody who can come look at that rash and say, well, what do you think it is? So
yeah,
photo, but yeah, but um, it's such a great team. I think we have a real advantage in recruiting.
yeah.
Um,
Well, and
yeah.
it's interesting. I think I shared a post last week or the week before where we have to retain first, right? Because
Yes.
it's funny, because if I were to look at clients, the clients that I work with that have good culture are so much easier to recruit for, right? And
Mm.
you talk to someone and you explain to them the culture, and or you introduce them to somebody in the culture, and next thing the engagement with the candidate is much higher, because
Mm.
and we often find that organizations, it's ways to market that culture and
Mm.
understand it. And it was funny, I had a really hard time recruiting home care docs in Canada years ago, because um, it wasn't as well adopted,
Mm.
and it
Mhm.
was seen as it just wasn't seen as beneficial in a lot of ways. And it was
Uh-huh.
interesting. And then there were some people that just they adored it, right?
Mhm.
Because
Mhm.
they all of the reasons that you mentioned earlier, right?
Mm.
Like, it was much
Mhm.
more of a full cycle relationship and stuff. Now,
Yes.
the drawback up here was driving around in the winter is a pain in the butt, right?
That is
So
a different beast. Yes.
right, so it's like you mean, but we had one. They actually hired a driver,
Oh,
right?
wow.
That was
That's
that was
awesome.
it. So they created their own little EMR,
Uh-huh.
and the EMR had a GPS attached to it,
Yes.
so they planned their day, going
Mhm.
from there, and then when they were in the car, they did their charting and stuff like that,
Mhm.
right? So
Mhm.
it was the best way to use the time, in between patients,
Mhm.
and stuff like that. And then
Yes.
you spend a lot of time planning who saw who based on geography, right? And
Yeah.
it was it was definitely there, and that's where the long-term care homes came in, is that
Mhm.
they could see 5 or 6 people
Absolutely.
at a time, instead of
Mhm.
one. So it made a lot of sense.
Mhm.
What is the biggest challenge stopping home calls from being more than 15%? Right, you mentioned earlier that
Mhm.
only 15% of the people have access to
Mhm.
it. Is it a financial thing? Is it a lack of resources? What's
Yeah.
prohibiting it from growing?
Um, so I think one is the payment model has to change because fee for service doesn't work if you're seeing 5 people instead
Yeah,
of 20, but that is changing. Um, and then now we are expanding, and our biggest limitation is growing the staff. Here's my
okay,
cat, Charlie, is recruiting now.
yeah,
Um, so our retention is great, but it's finding primary care clinicians like everybody in North
yeah,
America. And I think it's knowing that this is a viable model. It's
yeah,
just developing that awareness.
Yes.
Yeah. Yeah.
Well, and I think that's a cool part too, is just sharing it, right? And that's the goal with part of the reason I had asked you on this was because it's interesting to me. I've had good exposure to it in the past, and I do think that we need to start caring for people where they are, as opposed to creating monolithic hospitals and trying to serve everybody in the hospital setting, right? And it's it's luckily the US is a bit different because you've got more standalone clinics and stuff like that. We in Canada have massive hospitals, right? Like 150,000 square foot hospital that's trying to take care of everybody, right? And I don't think it works. And as communities grow and as people get older and older, it's just too hard potentially to get to the clinic that I think you do need to balance the two, right? So that's great. Well, listen, sorry, go ahead.
One last point around that. So much of what we do in primary care is not when we're face to face with the patient, when we're doing that coordination and the follow-up calls and the reviewing labs, that in a outpatient fee for service with a full panel, you've seen your patients all day. Now you have that second shift.
Yeah.
And we've not been able to capture the value of the work we do. And this is a model where we are able to, the work that we do best, we're actually able to incorporate that into our workday, not that second shift.
Well, it's interesting. Somebody, I read an article, now it was Canadian data, but it's probably quite similar to fee for service in the US, is there's about 19 hours a week of unpaid work. So, for those of us that work a 40-hour week, that's 50% of your additional of your week just in paperwork, right? And I often question. I'm not a bureaucratic person, unfortunately, or fortunately, depending. But I often wonder the value of these systems where we're predominantly using them to track cost more than anything else, right? So it's definitely interesting.
Yeah, it's a win-win for physicians, for our patients, for healthcare costs.
Yeah.
So I'm so grateful for you asking me on here so I can talk about how amazing this is.
Yeah, no, I appreciate it, and it's being live streamed to LinkedIn right now and YouTube, and my Twitter account. So
cool.
Yeah, so it'll get out there. We've had a few people make some comments and stuff like that. My friend Josh, who used to be in healthcare recruiting as well, he likes the notion of supportive care unit versus palliative care unit, which I can agree with. So lots of great stuff. So it was a pleasure, and hopefully we'll continue to communicate and chat and get to know each other. And I hope you have a very productive and great day. Thanks for doing what you do.
You bet. Thanks, Kevin. You take good care.
You too. Take care.
Bye.